mean, I can say fundamentally, I don't think that helmets are ever a good idea, but we'll get to that. We'll get to that in this lecture. I have no conflicts of interest to report. Right, so where does this word come from? So plagios is Greek for askew. Cephaly is Greek for head. Let me see if I can get rid of this toolbar. And so it's askew head, plagiocephaly. That's what it is. So what do we want to do today? We want to distinguish positional or deformational plagiocephaly from synostosis. We want to know how to monitor positional plagiocephaly to reliably identify worsening or improvement. And we want to know how to manage positional plagiocephaly. All non-positional, all synostotic plagiocephaly is simply a neurosurgical issue. We'll start here. So plagiocephaly has two main categories. One is synostosis. That's a premature fusion of one or more cranial sutures, which restricts normal head growth. That's actually a really important distinction when you're looking at heads and how they pattern. If that skull looks like it's been restricted across a suture, that's likely synostosis. If it looks like it's been deformed by external forces, then it's positional. So positional plagiocephaly is external forces cause deformation of a cranium, but that the sutures are normal. You know, you can palpate those sutures and see if there's ridging or if there's the more familiar little crack there. You know, and deformational plagiocephaly does not deform the skull base, but synostosis absolutely does. So if the orbital rim is odd, or if one occipitomastoid protuberance is lower than the other, that's a strong indication that synostosis is happening and not positional plagiocephaly. So patterns of synostosis. So sagittal synostosis is, give me a second and let me see if I can get back to my, there we go. Oh, no, it doesn't do that. Okay, so synostosis here is a normal sagittal suture. It's open, allowing for growth bilaterally to the left and right of the patient. But when there is a synostosis of the sagittal suture, there's a restriction across the middle. And so the head can take on a scaphocephalic or boat head shaped appearance and dolichocephalic. It's long. And usually these don't hide. You know, you should be able to look at heads with a sagittal synostosis and be like, that ain't right. It's about 45% of non-syndromic cases. The normal closure of the suture starts at 22 years. It may remain open into the 40s, but premature fusion results in noticeable ridging, and again, scapho and dolichocephaly. And these are all synostosis is essentially surgical in its management. A unilateral coronal is about 25 cases of non-syndromic. 1 in 2,250 neonates have this. It's similar to the sagittal suture in that it starts to close in your 20s, but may remain open to the 40s. And you can see here, here's normal. So it's allowing front to back growth on both sides of the head. But when you have a synostosis, it restricts growth and there's a compensatory growth on the other side. You get this frontal bossing. And you can see here the orbital rim is distorted. The whole shape of the head all the way down to the skull base has been distorted. This is the sort of a classic frontal plagiocephaly as the result of a coronal synostosis. And again, there's ridging of the suture usually. You can have a metopic synostosis. This is a little bit more difficult to diagnose because the metopic suture usually fuses normally at 3 to 9 months. But you can see that there's hypotelorism here. And when you look from the top, I mean, you know, trigonocephaly is not subtle. And you can see how there's sort of a protrusion of the orbital rims here. That's another strong indication. Often there's ridging here, but even that's not super helpful here because a lot of times normal metopic ridging occurs. So I think this is a tough one. You know, my rule of thumb is if you look at it and you think that ain't right and other people will look at it and that ain't right, send it along. We're happy to see it. This is less likely than sagittal or coronal synostosis, but we see a fair amount of it here. You can get a bilateral coronal synostosis. That can happen spontaneously, but this is a little bit stronger indication that you may have a syndromic situation. You get a bilateral restriction. So instead of a compensatory bossing on one side, both sides are abbreviated, and you get this real foreshortening of the frontal skull base, and so the frontal lobes can really be compromised by this. So the head does the only thing it can. Instead of growing forward, it grows up. So you get a brachycephaly, short front to back, and a taurocephaly. So the head tends to crown. It tends to be very tall. And you also get a bitemporal widening. That's another compensatory mechanism for skull growth in the absence of free coronal sutures. The lambdoid synostosis is the least common. This is a difficult one. This is a hard one to navigate between this and lateral positional plagiocephaly. The big we're going to talk a little bit about head shapes here, but you get this occipitomastoid protuberance. So the contralateral occipitomastoid looks lower than the affected side, and there's some compensatory frontal growth that happens. This does not happen when you've just deformed positionally one side of the back of the head. This is if you've got unilateral frontal bossing, that's a strong indication that you may have a lambdoid synostosis rather than a lateral positional plagiocephaly. Finally, I don't give these much coverage because, I mean, I don't think anyone takes a look at this and thinks there isn't a surgical problem. So, you know, these genetic syndromes can be striking. And if you see a kid like that, they just need to come see us so that we can figure out what to do. These often require distraction osteogenesis or some very complicated skull remodeling and suture release. So that's the synostoses. You know, mostly my point there was to help familiarize you with some of the visual patterns that may be at play for synostosis. By and large, my experience is that the community does a really good job of identifying synostosis. We see these kids really early, and we take care of them, which is very important because the earlier you take care of a non-syndromic synostosis, the better the outcomes are. I mean, the babies have such a capacity for plasticity that when you release the stenosed suture, it's like everything normalizes, and we can usually just do a strip craniectomy of the affected suture and call it a day, and then they just rectify themselves. So let's talk about the positional plagiocephalies, where an external force has caused deformation of a normal suture. The incidence varies by age. At about 6 weeks, about 16% of neonates have this. At about 4 months, about 20% have it. And then at 2 years, it's dropped down to 3.3%. 6 weeks and 4 months, I mean, these kids have a hard time moving their head initially. So when we lay them on their backs, as we started doing in 1992, the SIDS rate went down 40%, but the consults for plagiocephaly went up 600%. So I wonder if I can move this. Nope. So, you know, by the time they get to 2 years, they've had a good long time of independent head motion, independent body positioning, and they move themselves and their head, you know, puffs back out. It tends to be a self-resolving issue. So a lateral positional plagiocephaly, you get some occipitoparietal flattening. You can get some compensatory shifting forward of the unit of the same side. With a lambdoid synostosis, it's actually an alteration of the skull on the contralateral side. But here, everything is ipsilateral, and depending on how much force, time, pressure has been applied here, you can get an ear that moves forward or a ipsilateral frontal bossing. Again, the sutures are all open, and this is a classic view from the top. The occipitoparietal flattening. The occipitomastoids are still even, and there's no ridging of the lambdoid suture. And the ear can be shifted forward, which makes it a moderate synostosis. And there can be ipsilateral bossing of the forehead, and that would constitute a severe lateral plagiocephaly. Often this is secondary to head positioning preference, sometimes torticollis, and again, the inability to move the head early in life. The lambdoid suture is patent. Often this is, if this comes to my office, I usually do not need any radiography, so don't feel obliged to do that before you send them to us. And again, there's no growth restriction. There's just a time pressure curve that can translate through the ipsilateral side of the head. This is a straight up posterior plagiocephaly where, the kiddo wasn't looking to one side or the other, but the whole back of the head is flattened. Again, the sutures are open, and you can see it. It's just flat in back, and then there's biparietal widening. There can be bitemporal widening. So if it's just biparietal widening, it's a moderate posterior plagio, and if there's bitemporal widening, then there is a severe posterior plagiocephaly. And I just want to comment here that moderate, mild, severe. I mean, it sounds significant, but I don't put helmets on anybody. The only indication for me to put a helmet on a kiddo with positional plagiocephaly is if parental anxiety is high enough that they just are not comfortable letting this resolve. And that's my indication for a helmet. So don't take the mild, moderate, severe to heart too much. These are just labels that we have to put on it in order to grade it. I mean, it would have been better, if you ask me, to just say a grade 1, a grade 2, or grade 3. I think that would have made it less dire sounding. There's no neurocephaly, there's no hypoplastic skull base or anything like that. And again, the coronal sutures are patient. So there is a brachycephaly, right? We flattened it in back, and so it is shorter front to back. Sorry about that. Shorter front to back. So there is a brachycephaly, but there is no neurocephaly. So just a little summary chart. So for lambdoid synostosis, persistent unilateral positioning, it's kind of indifferent. Doesn't matter if it was happening, but this is always the case. The kid always prefers one side or the other for lateral positional plagiocephaly. Is torticollis present? I shouldn't say absent, but it's immaterial to it. But often the torticollis or a tight SCM can help, or motor delay. And it's important to recognize that plagiocephaly does not cause motor delay or any cognitive deficits. We're very sure on that. We're going to return to that a little bit later in this presentation. But it is absolutely the case that people with motor or cognitive delay are more likely to have a positional plagiocephaly. There is a bony ridge on the lambdoid if it's synostotic. It's absent if it's positional. The occipitomastoid bony protrusion, the skull base from the back looks uneven when it's synostosis. It is even when there is just positional plagiocephaly. Frontal bossing happens contralaterally with lambdoid synostosis, but more it happens contralaterally with synostosis, and it's ipsilateral with positional plagiocephaly. If you look at the flattening in the occipitoparietal region and there's frontal bossing on the other side, that's a strong indication that you should send the kiddo to us. If it's on the same side, like that forehead just got pushed forward, just like the back got flattened, that's a strong indication that it's positional. Ipsilateral ear displacement is posterior because there's skull restriction in lambdoid synostosis. Here it's been pushed forward, just the same as this. It is a forced time curve, and if it flattens enough, then the ear will move forward, and if it flattens even more, then the forehead will boss. And if you look at the top, of the head, you can see that the head is shaped like a trapezoid in lambdoid synostosis because of the growth restriction, and it's shaped like a parallelogram in which one side has been shifted forward in lateral plagiocephaly. Again, we'll have some pictures in a second. So here is lambdoid synostosis. You can see the occipitomastoid prominences are uneven here. And here's a CT scan showing the loss of the normal suture, of the lambdoid suture. In positional plagiocephaly, these occipitomastoid prominences are even, and there's just flattening. We're looking at the head, lambdoid synostosis. It's flat over here, and it's a contralateral bossing. Here, it's flat here, and it's an ipsilateral bossing. With a lambdoid synostosis, there's flattening here, and this ear is behind this guy. Here, it's flattened here, and this ear has been moved forward. Again, it's a time pressure curve, and it's just how long was he laying on that side and how much deformation did translate through the skull from back to front. You can see here with lambdoid synostosis, it's growth restriction. So it's ipsilaterally, the forehead has been pulled back. So this is a trapezoid. Here, it's a parallelogram. Everything has been shoved forward. There's a trapezoid, and there's our parallelogram. So looking down on top of the kid to see which way the ear seems to have moved, if at all, in relationship to the flattening in the back of the head is a big part of this exam. So in differentiating bicoronal synostosis, which is relatively rare, from posterior positional plagiocephaly, there's brachycephaly in both, but there is pterocephaly only in synostosis. There is no pterocephaly in posterior positional plagiocephaly. The widened lateral diameter of their head is frontotemporal. Here it's parieto-occipital. Often there are syndromes involved with bicoronal synostosis. Very rarely is that the case, although if you have a syndrome and you are motor or cognitive impaired, you are more likely to have a positional plagiocephaly, including a posterior positional plagiocephaly. This is often, bicoronal synostosis is often associated with hydrocephalus. So the kid will have pressure issues. There'll be other things going on with them, maybe developmental delay. Here, it's not really an issue. Coronal ridging bilaterally here and not here. And the hypoplastic orbital rims, because of the front to back restriction, is almost invariably present with bicoronal synostosis. Whereas with posterior positional plagiocephaly, their face looks essentially normal. So, so front to back, so this is bicoronal synostosis. You can see it's pterocephalic, and there's front to back shortening, and here's flattening of the back of the head. It's also shortened, but here the head is tall. Here the head is kind of not. With bicoronal synostosis, you get this real widening of the frontotemporal region. With posterior positional plagiocephaly, it tends to be posteriorly. The widening tends to be parieto-temporal, or occipito-parietal, really. And here you can see their hypoplastic eye ridges. This face looks flat and elongated rostrocaudally. You know, if you were to hide everything behind here, you would deem this face to be essentially normal. Okay, so with, you know, and I think this is so a summary slide. Like, if you are, is this posterior positional plagiocephaly or is this bicoronal synostosis? And if you look at this kid with brachycephaly and you go, wow, that looks weird, send them to us. If this just looks like the back of their head got pushed in, then less likely to send to us. With bicoronal synostosis, it looks like the front of the head has been pulled back and the forehead is very high. Here, the forehead tends to be okay and the orbital rim is okay. Here, the orbital rim is pushed back. Here, because of the growth restriction, it's a frontotemporal widening, and here it's an occipito-parietal, sort of posterior parietal bulging. How do you monitor positional plagiocephaly? Like, I actually don't do this anymore because I sort of reassure the patients and, kind of send them on their way, tell them to call me if anything changes. But you may choose to do this. Here is a grading scale. So for lateral versus posterior deformational plagiocephaly. So for lateral, a mild is just flattening on the back of the skull. Moderate is the ear has been pushed forward ipsilaterally. And a severe is there's ipsilateral frontal bossing. For posterior deformational plagiocephaly, it's just flattening in back for mild. There's widening of the parietal diameter if it's moderate, and there's widening of the parietal and temporal regions if it is severe. You can measure these indices. This exists out there. I never do this. It is never the case that I find that this is helpful. How do you manage plagiocephaly? Okay, that's the key. So patients in your office, and the first question you need to ask if their skull is not shaped normal is this deformational or is it synostotic? And if it's synostotic, send them to a craniofacial specialist. It may be that you need to do radiography to be sure one way or the other. If it's no, which is red, so green is, yes, it's synostosis, send them to us. Blue is, I can't tell. It's reasonable to get radiography. It's reasonable to send them straight to us. Often, by sending them to us, we can avoid any radiographic interrogation, although ultrasound's a helpful adjunct that has no radiation, so that might be an option. If the answer is no to clinical synostosis, then it is entirely appropriate to manage the patient, although we are always happy to see them. So here's a foreview of the X-ray. That's one way to evaluate radiographically. It's a foreview skull X-ray. So it's AP, lateral right, lateral left, which gives us both the left and right coronal sutures, as well as a Townes view, which allows us to see the lambdoids really well. You can get a CT scan. This is a CT scan of positional plagiocephaly. You can notice that all the sutures are open, but both of these involve a lot of radiation. You can also do an ultrasound. When you order an ultrasound for this, you have to be very careful to order not a head ultrasound, but a suture ultrasound. And it is very helpful to let the radiologist know what suture you are suspicious of, because they kind of have to do the whole length of it to make sure that it's patent through and through. So a lot of people, when I tell them about ultrasound for plagiocephaly, they seem surprised. So it is something that's been vetted. It is the case that patent sutures are reliably identified on ultrasound images without inter-observer variability. In my experience over the past 10 years, it's been very helpful in avoiding radiation. It turns out that skull X-rays, CTs, and ultrasounds can all give us false negatives and false positives, and in my experience, at about the same rate. So none of these is perfect. So there's really no reason not to start with something that doesn't have radiation. And again, if you want to send them our way without radiography, I think that's fine too. I think ultrasound imaging should be an integral part of the evaluation of this. Okay, so if you suspect clinical synostosis and you do radiography and it says synostosis, great, send them to us. And again, if it says no, it's positional, then it's PCP management. You really want to do a developmental eval and a full clinical eval. The reason you want to do a developmental eval is because kids with plagio are more likely to have developmental delay. Positional plagiocephaly does not cause developmental delay, but if you have developmental delay, you are more likely to have a plagiocephaly. So if you see a kid with deformational plagiocephaly, non-synostotic deformational plagiocephaly, do a developmental eval. Make sure that there's not something going on that's made him or her predisposed to a positional plagiocephaly. Here is the study that put to bed our worries about deformational plagiocephaly causing delay. And this is, Pediatrics 2010, Speltz et al., in which they conclude that deformational plagiocephaly is a marker of elevated risk for delays. Pediatricians should monitor closely the development of infants with this condition, but it is not the case that the plagiocephaly causes that neurodevelopmental delay, right? No evidence that plagiocephaly causes neurodevelopmental delay. Sleeping supine is clearly associated with motor delay. So it was an interesting trade-off. Putting kids on their back avoided SIDS. They reduced SIDS by 40%. However, there is a motor delay, but supine kids can catch up to prone kids by age 18 months. Gross motor delay, low tone, and torticollis are all associated with the development of plagiocephaly. But again, it does not cause those things. It is just associated with them. Okay, so you've done your full developmental eval. Is there developmental delay? Well, you may have to do developmental education. You may have to do PT. If there is torticollis, you should absolutely do PT. Often it is a very successful way to take care of a rotational tension in the child's neck that allows the head to move more freely and allows the positional plagiocephaly to resolve. If you do plagio management, there we go. If you do plagio management, then you need to so the question you need to face it. So you've done a developmental LA, you're doing positional plagio management. And so you need to think, is the kid less than 4 months? Is the kid 4 to 6 months? Or is this kid 6 to 12 months? Because it's going to change how you manage things. So let's take a look at how that works. So we're going to take those different time frames. You definitely want to you just get a sense of how bad it is. I mean, I think it's fair to share that with the parents. I would urge you to really not get too caught up in the emotional tenor of these labels. You can almost call it, mild as a 1, moderate as 2, as severe as 3. I would urge you maybe to use that language so people don't become alarmed in your office. If the kid is less than 4 months, whether it's mild, moderate, or severe, I would absolutely do repositional therapy and tummy time. If you just facilitate them getting off their head, that brain pressure, the steady pulsatile nature of the brain will push that skull back out. Follow them up in 6 to 8 weeks and see if there's improvement. If it is yes, green line is yes, follow up versus PRN. And if it's no, are they 4 to 6 months? And then check back 4 to 6 months. And again, if there is improvement, if there's not improvement and they are still 4 to 6 months, you can still try repositional therapy and tummy time and then iterate this. And if it's yes, then they're okay and you're all right. So what is preventive repositioning? So here's a set of instructions that can be given to all parents. Now, there should have been a PDF given to everybody as part of this lecture. That PDF has a high resolution copy of the handouts. I think I have a copy of the handout, but all this information is in a handout. You can literally just copy it and give it to your patients. These are, because all kids are going back to sleep, they are going to sleep on their backs. All parents can potentially benefit from getting this set of instructions when their kid is between age 2 and 4 weeks. And that is alternate left and right occipital position with sleep, minimize time in care seats and other devices that promote a supine position, and then make sure they get plenty of supervised tummy time, at least 30 minutes per day. If the child resists, build their, you do a little bit at a time and develop their ability to tolerate. Just gradually increase that time to as much as possible. The less they are on the back of their head, the more their natural rounded head shape will emerge, even if there's some initial flattening. If you have a kid who comes in with plagiocephaly, here is a set of instructions you can give to them. Active repositioning when they're sleeping and when they're playing. If they're laying on that affected side, actively reposition them, put them on the other side. Place the rounded part of the head against some kind of thing that won't compromise their sleep safety, although this is mostly sort of with activity. So I'm not actually advocating for sleep positioning. This is during more like play or awake resting. Just make sure that they can't roll back onto that affected side. But that's something that's going to be much better done with some direct observation. You don't want to just necessarily use a pillow or a foam positioner to do that when they're asleep because of the risks to their breathing. You can also position the crib to encourage therapeutic head positioning, change that crib so that everything interesting and engaging when they're in that crib laying on their back is kind of forces them to lie on their unaffected side. You can alternate which side of the head the crib is on. You can alternate which side of the changing table the head is on. And you can place all toys and entertainment so that the child turns to the unaffected side. If the patient has torticollis, they should absolutely get PT, and there should be some neck exercises with each diaper change. Repeat each exercise about 3 times, which adds about 2 minutes extra per diaper change. You can do head rotations, and you just literally holding the patient's head to the contralateral side and hold for 10 seconds on each side. You can do the head tilt, same thing. Instead of rotating the head, though, you're wobbling the ear towards the shoulder on the side that needs to be stretched and hold for 10 seconds. And then for children greater than 3 months, you can hold the kid in a swivel chair and have the parent go to the side where they have to turn their head away from their foreshortened side. So, use mom as a prop to force the kid to look in a different direction. So those are all ways to manage torticollis, information to give to the parents. But again, if the patient has torticollis, I would strongly recommend having them see PT. So if you're seeing a kid between 4 to 6 months, you need to know what the severity is. It makes a difference here whether it's mild, moderate, or severe. So if the kid's got severe, the algorithm's different than mild and moderate. So if it's mild or moderate, it's the same algorithm: repositional therapy, tummy time, follow up in 1 month, and look for improvement. If there is improvement, follow up at 6 to 9 months. And, by the time they're 6 to 12 months, by the time they're 12 months, really, their skull's starting to ossify. If there's no improvement, then potentially there's helmet therapy. Again, I am not a big fan of helmet therapy. This is I think that as the provider, you get to decide what to do here. Some people, I would think in all cases in which, regardless of the degree of reassurance you provide to the parents, they are still very anxious, give them a helmet. If you, as a practitioner, feel that it's just very important to intervene on this and get them a helmet, that's fine. Do keep in mind that not all insurances will pay for the helmet therapy. So equipping the parents with the information they need to make an informed decision at the orthotist when they find out how much it will cost them can be helpful for them making a decision. So if there's no improvement at 1 month for mild or moderate, if the patient's 4 to 6 months, helmet therapy is an option. If it's severe at 4 to 6 months, helmet therapy is also an option. And again, at the end, I'll get to some of the justifications behind my reassurances that no helmet is ever needed. If they do helmet therapy, you can follow up every 2 to 3 weeks and watch for improvement. And then if the helmet stops working or the plagiocephaly is completely resolved, you can have them follow up versus PRN. That's your prerogative there. If there's no improvement, even in helmet therapy, I would just send them to us. That's not normal, not at this age. If there's no improvement at 18 months, that's just called, boy, my skull grew up and it's thick now. At 4 to 6 months, the helmet for positional plagiocephaly should always work. And so if it is not, send them to us. If you're seeing a kid at 6 to 12 months, the severity matters. If it's mild, the algorithm is different than if it's moderate versus severe. If it's mild, you can follow up at 1 month and see if there's improvement. Of course, you've given them the positioning advice, and if there's torticollis, you've treated it. If there's improvement, you can follow up versus PRN. If there's not, then again, we're back to potential helmet therapy, and this all looks the same. So if the helmet therapy didn't work, that's a problem. So, okay, is a helmet ever necessary? It's just aesthetics. The brain is safe. Reassure the parents over and over. The brain is safe. Kids have big heads and small bodies. They usually don't have too much hair. And it's really important to realize that people look at faces, not heads. I like to tell parents who often have a nice full head of hair that I don't even know if they have a back of their head. I don't really care. I can see their face. I'm fine. So positional plagiocephaly poses no demonstrable threat to neurodevelopment, right? This is all just aesthetics. So this article came out in 2011. It was done in New Zealand, and they looked at 129 children with a mean age of 4 years. Okay, so they all were diagnosed in infancy with deformational plagiocephaly or brachycephaly. There's no synostosis here. So, their use of the word brachycephaly here, that's just the straight midline posterior plagiocephaly. So deformational plagiocephaly is lateral plagiocephaly, and deformational brachycephaly is posterior plagiocephaly. That's just slightly different language. All patients were managed with repositioning therapy. If they had torticollis, then they got PT. If there was a minor neck imbalance, home stretching exercises were recommended. Again, no helmets were prescribed for any of these patients. And then they were followed up for the study's purposes anywhere from 3 years, 3 months to 4 years, 9 months. What did they find? They found that 61% of head shape measurements reverted to the normal range, whether they were mild, moderate, or severe. 4% of these kids remain severe at follow-up, okay? Brachycephaly improved more than plagiocephaly. So if it was straight midline flattening, it improved more than lateral plagiocephaly. And facial and frontal asymmetry reduced almost to nil. So even if they maintained a pretty robust plagiocephaly, their facial and frontal asymmetry was essentially normal in everybody at last follow-up. Okay, so here is the breakdown. The black areas are kids who were severely plagiocephalic in infancy. The gray is moderate, and the light gray is mild. Then here's the number of patients who were normal at time 2. So when they were followed up as older kids between 3 and 4 years, these kids were normal on the left. Then there's mild next to it, then there's moderate, and there's severe, okay? So even most kids with severe positional plagiocephaly, even at time 1, became normal by time 2. A whole big chunk of them were just mild at T2. So really, this gets better without a helmet. And they concluded from this data that overall head shape measurements, parental concern, and developmental delays in infancy showed a dramatic improvement when remeasured at 3 and 4 years of age without any use of a helmet, which again, they're expensive. These helmets are expensive, and a good proportion of insurances require either copay or full pay for these helmets. I was curious about the kids, the 4% of kids who were severe at time 1, who remained severe at time 2. But they didn't mention what happened to them. I actually wondered if they got surgery. Did they, was there surgery involved here? So I emailed Lynn Hutchinson, the lead author, and I just said, "Hey, how did you manage the few children who remained severe at follow-up?" And she said, "Well, there wasn't much we could do, but having said that, the parents were not worried anymore, and the plagio wasn't that obvious either due to hair growth and the smaller relative size of the head." No one can guarantee an outcome here, but your child will grow hair. Your child's body will catch up to their head. People aren't even noticing this. It's usually a mother-in-law or one member of the family, or maybe a couple members of the family who just seem to have fixated on it and just can't let it go. But everyone else treats the kid like they look normal, because mostly they do. Another thing I tell parents is just walk around and look at how many jacked up head shapes there are out there. I mean, if there are plenty of people who don't have a lot of hair, myself included. I've got, pretty prominent coronal ridging, and, heads are not smooth and round. And by and large, we don't care. As long as their face is normal, we're okay. So it is entirely okay to urge parents that and to just comfort parents and let them know that as long as they do some positional, therapy, try to keep them off the affected side, as the child develops, not only does most of the deformational plagiocephaly resolve on its own, but as their body catches up to their head size and as they grow hair, any amount of plagiocephaly that remains is almost not noticeable. And if they remain anxious, write them a script for a helmet and an orthotist, but just again, equip them to be able to handle the financial decisions they may be faced with.